Good afternoon, everybody. Did you have lunch? Hands up. Not bad. Okay, right. Now, this is important, this session. And it's important for two reasons. One is we had a great morning session about dramatically changing healthcare. That's essential. What's that? Oh, the clicker. Thanks. That'll be useful. Dramatically changing healthcare. But the second reason is all of us become patients from time to time. One day or other. And it's really important for all of us, both on a personal level and on a professional level, that we should move medicine to more personalized approaches. There are a number of barriers. So what we heard this morning was basically about a whole lot of really cool stuff you can do by connecting existing data and generating new data. And to give you an example, I would argue that this thing here on my wrist is most likely a much better predictor of dementia than anything else we do on the planet. It's just one kind of example. But what I'm going to talk about is much more about how do we relate our ability now to interconnect everything with everything to the really exciting science that's now happening. Because that is not going to happen automatically. Simply connecting what we do today is not going to bring us personalized medicine. And I want to show you how and why and what we need to do about it, or the kinds of things we need to do about it. Now, if you talk to a clinician, doctors, and indeed patients, everybody tries to give the best possible personalized therapy they can. And our ability to do this has accelerated dramatically with the explosion of science. It actually started with the Greeks, Galen and friends, and has continued and accelerates faster and faster, as we all know. Genomics, genetics, all of the stuff, when we sequenced the human genome, we said, okay, this is, some of us, not me, said, this is the answer. Actually, it turned out it was partly true, but the answer depended on a whole lot of other things. Data integration, really sophisticated molecular technology and stuff. But you put all that together, huge acceleration. So where we are today, this is a kind of history. We've always tried to be personalized. Science has developed. Where we are today is we're basically using a lot of cool science, but we're using it. We're not using the latest science, and our whole strategy is statistical. So we say, if I take 100 people who have what I call breast cancer or Alzheimer's, and then I give them some treatment, sometimes a drug, sometimes surgery, on average, what happens to these people? And that then gives us guidelines. And so when you go and see a doctor, the doctor says, you've got disease X, gives it a label, and the guideline says you get this treatment first, and then you get that treatment, and then you get that treatment. And those are guidelines, and they are pretty rigid. They're rigid in the minds of the doctors, especially in the States, because they get sued if they go too far outside. They're rigid in the minds of the regulators, and they're even more rigid in the minds of the payers. And so if we really want to change healthcare, and particularly some of the newer things we can do to help patients, we're going to have to do more than just connect up data. We're actually going to think about how do we leverage the whole system, the whole healthcare system, from the patient all the way through to the insurance companies, payers, and all the rest of it. How do we leverage that system to make the kind of changes that we all understand are absolutely essential and necessary? And that's the kind of thing I want to talk about briefly. I would say today, for cancer, for the diagnosis and administration of a cancer drug, I believe this is no longer possible. It can no longer be done by an oncologist without very significant assistance from computer algorithms. It is no longer possible, and I would argue it's not ethical. So we're already there today. How do we get there? Why do I say that? Why is it no longer ethical? These are a whole series of drugs, some of them new and some of them a little bit older. And the black bit is the responder, or the blue bit is the responder. The red bit is the non-responder. What that means kind of on average, and there are a lot of others, what that means on average is we are giving drugs to somewhere between a half and 2/3 of the patients who've got cancer, and they will not derive benefit. It's an extraordinary situation. That's what we do routinely all around the world. And there is now data evolving to show that if you give people a cancer drug to whom they do not respond, they die quicker than if you did nothing, which is also kind of really disturbing. And all of this is the consequence of the advances we made in running, actually at the time, really good statistical powered studies to show, on average, this one's better than that. But where we've got stuck is that whole system and way of thinking is deeply embedded throughout society and in all of the stakeholders. And what that means is we are effectively killing people quicker than we would if we did it properly. Not to mention the costs. So a lot of these drugs are expensive. And to give an expensive drug to somebody who doesn't respond and it makes them die, or it may make them die quicker, is even more crazy. So we have to be able to fix this. Now, one of the ways we can fix this, so most organizations, not all, but most organizations everybody understands cost, mostly. And so one of the tools we can start to think about is how can we demonstrate that better healthcare is cheaper? Every time we can do this and we can generate the data to persuade people, we will move more towards personalizing medicine. And so my focus has been how can we create the right kind of environment in which we can demonstrate cost and health benefits, because that's how we'll create new products. We create an environment where we can create new products, and we also change the healthcare system, which allows us to create even more new products. I think this is this is a very important thinking as to how do we change, not just interconnecting people's data. Did they go for a walk? What's their grocery bill look like? But how do we actually get these important new therapies and treatments to the right people at the right time? And these are just some ideas. So let's focus the treatment on responders, people who need it. Let's make sure that we can demonstrate it's effective. And I must say, in Finland, actually, we've made in the last 5 years dramatic progress in creating a partnership between 3 ministries, that is health, education, and industry, in order to try and create in Finland an environment in which we can actually test. We can actually create these, if you like, test beds to show not only do the patients do better, but we save money. And then the innovative products that we're creating, they will fit into this. How do we give better health and save money? And finally, the other thing we can do, which is really important, phase 3 data, classically used to approve drugs, is frequently unhelpful in the real world. It doesn't tell you what's going to happen to this drug in real world. And that's why more than 25% of the budget of most companies, pharma companies, is running phase 4 studies, which is to find out what happens in the real world. So why don't we do it the right? Now we can collect data in the ways that we've described. Let's do it better, and that's the point 4. So how do we run real-world clinical studies to show the real effect of whatever it is, an app, drug, surgery? So these, in my view, are 4 of the key ways in which we should approach this whole issue of transforming medicine. This is just an example that I'm not going to go through in detail. This is a test for, this is what do you do with a patient who might have breast cancer? And you must have seen the arguments about, is mammography helpful or not? There are lots of new really cool blood tests. Okay, so how much does it cost and where do you put it? So it's how do you stratify? There's new technology. How do you stratify the technology such that you have the most effective series of pieces of information in order to make sure that you can best treat that individual person? And this order, by the way, will not be the same for all patients. So even the order in which you do the tests needs to be personalized. I'm one of the many fathers of this particular approach. As I'm sure you all know, in the last few years, there's been a really dramatic demonstration of what happens when you give the right medicine to the right right patient. And this is a medicine that hits a particular cancer mutation. And as you can see, when you can see the patient, it's the same patient who had a metastatic melanoma. You give them the drug, just one drug, and it all goes away. However, 23 weeks later, they all come back. And what that tells me is that we need to understand much better how to predict combinations of drugs. And I just want to share with you one of what I think is the most innovative and interesting approaches to how do we predict which patient needs which individual combination. And it's a company called Caris Life Sciences in Phoenix and Dallas that I've been associated with for about 5 years. And they did a very interesting thing, 10 years nearly. Anyway, they did a very interesting thing. They took all of the data in the literature that spoke to, does a particular cancer drug, is it more likely or less likely to work in a particular paper? The world's knowledge. They put this into a predictive algorithm, and then they set up a set of tests that tests about 60 or 70 different things. And I have to say, if you have cancer and you go to a hospital, only about 3 or 4 of these things will be tested. So this is an important point about actually needing completely new types of data to integrate into our network of information. Anyway, that's what they did, and they set up an observational study. Sorry, I didn't finish. So they now have the largest, I gather it's the largest private cluster outside IBM. So they have a really big investment in information management. And what they've done is that originally they used this information to predict which of all the possible drugs, which are about 300, is more likely to work in this patient and which is less likely, on the basis not of which tumor they had, but on the which, was it colorectal, was it whatever, breast, but on the basis of what was the molecular pathology of the tumor. And then the drugs, this is what the clinician gets. You can see the clinician gets, drugs in green are more likely to work, drugs in red are less likely to work, and drugs in gray, we don't have any information. Anyway, then what they did, and this is for the experts, this tells you the kind of information they're collecting. I just point out that sequencing is a rather small part of the information you need to collect. And I personally do not believe that sequencing is ever going to give us, sequencing of the DNA of cancers is ever going to give us a reasonable degree of predictivity. And that's an important point that we can debate. You can see it's mostly about measuring proteins and other changes. Anyway, the really interesting thing happened about a year ago when they asked the question of their observational database, okay, so what happened to the people who got the drugs recommended by the literature versus what happens to those that didn't? And this is just one small piece of data from ovarian cancer patients, and giving the patients the right drug, even if it had never been tested in ovarian cancer, gave us an increase in survival of 2.5 years. Using old drugs, but with the right diagnostic and extensive information management. And now what's happened, of course, is there's so much data in the observational database that they moved away from the original thing. So it's just an example. We need more data. It needs to be connected. When you do that, just the diagnostics with information can produce much better results. That's much better than any drug that's ever been tested in ovarian cancer. I don't have time for this. There's some extraordinary, interesting work in Helsinki. This is at the university at FIM, where the information generated is about testing the drugs on patient samples, individual patient cells, ex vivo, 350 drugs tested. This is part of the new. These are just new, cool technologies. Here's another new technology that I'm involved in. If you see the little blue thing down the bottom, it's a T-cell receptor that has a potency of 10,000 times the best possible antibody. It's an immune oncology. And this is redefining cancer, because cancer is no longer where did the cancer come from, it's what peptide, what is it displaying on its surface. These are new classes of cancer that are coming, and all of this will need information. Finally, I want to talk about genetic risk and cardiovascular disease. There is a paper submitted for publication that, in my view, is revolutionary. It's a paper that's been put together by an international group, some of whom are, actually the leaders are in Helsinki and Melbourne, Australia. And the conclusion of this data is that if you do a thorough analysis of our genome, just using the genes, you can predict cardiovascular risk better than all of the existing clinical data, better than cholesterol, high blood pressure, obesity, I mean, you name it, all of that, triglycerides. So genetics now, this hasn't been published, it's about to be published, genetics for the first time in terms of risk is now overtaking all of our knowledge about cardiovascular disease. It's an extraordinary moment in the evolution of medicine. And this is going to be really interesting. So what do we do about this? And I think in the context of apps, there's a very, if people drive fast sports cars or have a lot of accidents, they pay more. I think if there needs to be some really creative thinking in society, using apps about grocery bills and exercises, and this is, by the way, this is a cardio compass study in Finland, that is also absolutely pioneering the approach of how do you use genetics to manage cardiovascular risk, and this is done in combination with everything else. But there's some really new, exciting ideas, not just measure everything, but how do we actually get some traction into this so we can actually save lives, we can actually stop people from dying from diseases they don't need to. And this is the best model I've ever seen of how we're going to do this. But in order to do that, we're going to need to agree in society, like we've already agreed, that people who drive fast cars or people who live dangerously pay more. People who live dangerously in a health sense, in some sense, need to be rewarded for their thoughts. Anyway, so I've talked about clinical trials. I think just in summary, in my view, the personalization of medicine is essential for further progress in medicine. We will not get there with the kind of approaches we use. I mean, time and motion studies and all of that's fine, but that doesn't bring us the huge change we need. We could generate, healthcare is anyway between 10 and 20%, and if you look at the downstream consequences of sickness in society, it's probably more like 30+% of GMP of certainly countries like the States and Finland. Huge. Because we don't measure it. So there is really huge opportunities to do this. We need to change the success metrics of healthcare such that they're not rewarded just for following the rules and having patients in and out the door. They're rewarded for bringing real benefits. That's a big problem. It is starting to happen, but it's very, very slow. And if we can do all this, this will create a market for all of the kind of cool new products. I'm extraordinarily enthusiastic about the opportunities. I would just say it is pretty challenging. And in the context of making these changes, I think we need to be revolutionary, but we also need to engage the healthcare providers and talk the language that they understand. And the common language here is benefit and cost. Anyway, it's a fantastic time to be in this area, and the opportunities are absolutely enormous and wonderful. Thank you.